All right, we are live. Welcome, Idle Spine and Sports PT community. I'm Dr. Steve Oswald. I will be talking with you again here for our tri-weekly series at this point now, where we're doing some community education. Today's topic is going to be vertigo. If you haven't had a chance yet, go back and review our shoulder rehabilitation exercises, our knee pain, anterior knee pain lecture we did last week, and then we finished it off with carpal tunnel. So this is series number 4, so we're logging a lot of FaceTime together. Again, today's topic, vertigo, oftentimes very, very common condition. In fact, it's really the second leading cause of dizziness complaints that people go in and see their primary care provider for. Most of us will, a lot of us will experience some sort of vertigo over a period of time, and there's a lot of reasons why that may be. Most folks don't understand that vertigo is a treatable condition beyond just taking medication. In fact, medications oftentimes do not help with true vertigo complaints, and especially that physical therapists treat vertigo. In fact, we're one of the premier professions that specialize in the treatment of vertigo and vestibular conditions. So that's why we're talking about it today, because it's something we see commonly in the clinic, and with true positional vertigo, which we'll talk about in a moment, it's one of my favorite things to treat, because it's one of the things that we can make an immediate change with, and oftentimes fix it within 1, 2, or 3 visits kind of max. We can really hammer this thing out and fix you almost immediately, even if you've been having symptoms for quite some time. So when we talk about vertigo, again, that is a term that's often thrown around to describe a whole series of complaints where we just don't feel well or feel dizzy, right? And it gets confused with true dizziness. And so I wanted to differentiate our terms a little bit when we talk about vertigo. Vertigo in and of itself should be a feeling of spinning or disorientation where you feel like you're on a boat and moving, but you're not moving, where the world around you is spinning and moving, but you're truly not. So it's that disorientation in response to feeling or sensing movement when it's not happening. Dizziness, especially lightheadedness, is a very different symptom and a very different system within the body that is maybe going awry that will give you symptoms. And so that lightheadedness feeling versus a spinning sensation, it couldn't be any more different. We don't want to confuse the two. Also, sometimes you may come across a bigger word called disequilibrium that kind of is used to describe symptoms like this. And that's just a general sensation of feeling off or unbalanced, or like you're going to lose your balance at any moment. Again, different than the feeling as though something is moving when it's not. All those 3 different types of symptoms, excuse me, not symptomatic, I promise. All those different symptoms are suggestive of certain ailments or certain aspects of your body being awry, right? Now, if we are experiencing those symptoms of spinning, right, there still may be several reasons why that is happening. By far, the most common reason for experiencing vertigo symptoms is from a phenomenon called benign paroxysmal positional vertigo. Very long. We shorthand it to BPPV. Or also what's known as positional vertigo, right? Or just even vertigo, because it's so common. It's the most common way that we describe it. Benign paroxysmal positional vertigo is roughly 2/3 to even 3/4 of the reasons why people experience vertigo complaints. So it's, again, very common. We name it that way because it's benign and that it's not malignant. It doesn't grow or become worsened over time. It obviously has to occur, and so it is not normal, but it isn't something that manifests and continues to worsen over time. It's paroxysmal in that it came about without a known reason or rationale. It's positional in that certain positions consistently provoke your symptoms, and you get vertigo complaints, hence BPPV. This phenomenon is strictly mechanical in nature, and by mechanical I mean there is a true anatomical reason for this condition to exist, and it may sound crazy. Hear me out though. This is true science. It comes about from crystals deep in your inner ear being in the wrong place. There are calcium carbonate, or otherwise limestone crystals in the middle portion of your ear that do serve a purpose. They can become dislodged and in the wrong area, and that will elicit your symptoms. To kind of explain this a little further, and to help to justify the way that we treat it, I kind of wanted to show you and share with you a little bit of the anatomy. I'm an anatomy junkie, so you're going to have to bear with me through some of this. But if we kind of show you how the inner ear is structured, we got out our netter here. There's a lot of stuff going on here, right? But this is the anatomy of the inner ear itself. There are three portions of the ear. There's the outer ear, which is what we think of as the ear itself, right? Outside of it, and then the ear canal. There's the middle ear, which is mostly air and then bony material, right? That's where most children get their ear infections, is that middle ear. This is where we take vibration from sound and convert it into liquid on the inside. So it's like it serves the purpose of kind of harnessing vibration and bringing it into the inner ear itself. But most of the function of the middle ear is auditory. It doesn't have anything to do with your balance. The inner ear itself houses small organelles for sound, right? So that is important, but then also sensing head and body position and accelerating and decelerating. Middle ear infections can happen, but they're not as common as middle ear infections. If you do have a middle ear infection, that can lead to some of these symptoms, which we will touch on in a moment. When we look at the anatomy of that inner ear, you'll notice just a lot of stuff going on. But the key areas I want you to focus on are these rounded structures that look like tubes here. These are what are called our semicircular canals, okay? We have 3 of them in each ear, so 6 total, and they're oriented in a way where they can help orient your body, help sense orientation in your body in 3 dimensions. That's why there's 3 of them. They tend to sense, these will sense head positioning and movements of the head in kind of our 3 kind of key motions where it's forward, backward, side, side, and rotating, right? Just hence helping sense head position in all 3 planes of motion. This area is filled with a thick gelatinous fluid called endolymph, and in the inside of the a different portion of the inner ear, that portion here where we see the utricle and saccule, what we're pointing to here, that area of the inner ear serves the purpose of helping sense accelerating and decelerating. So like going up and down in an elevator or speeding up or slowing down in a car, that helps to sense that position. That area of the inner ear uses those limestone crystals to help displace little hair follicles to help sense movement. Those crystals can slough off that area and make their way into these canals. When we have that little rock in this area where there should not be a rock, just pure liquid, banging around, it senses off, it fires everything, right? So you get this unnecessary, untrue sense of massive movements of the head within that specific canal. And so as you can imagine, it's quite uncomfortable. Anybody that's experienced it will tell you it's awful, right? It's debilitating. And you try to refrain from putting your head in those positions that provoke it, because again, it will stimulate it when you are stimulating or moving that lymph in that canal. So the treatment is to just get it out, like to dump those rocks out of that canal, and you can do that by literally just repositioning your body and taking your head through a series of movements in attempts to try to direct those rocks out of that semicircular canal. There is one canal that tends to be the most common perpetrator of this phenomenon. It's what's called our posterior canal, right? It's this one that's right here. Over 90% of the time when we have vertigo complaints, when it's positional vertigo, it's that canal that ends up having that little rock in there. Each different canal has a slightly different means of trying to dump it out, but most of the time we just aim for this one, and that's the one that will get you symptom relief. There is oftentimes no clear explanation for why this happens. We do know that a direct trauma to the head, like a car accident or a fall or some blunt force trauma, especially to the side of the head, the temporal lobe, can cause this phenomenon to happen, so it is common. We do know that people with osteoporosis have a higher likelihood of developing this. It is more common as we get older, especially after age 65, to develop these symptoms just spontaneously. But most of the time we cannot point to a direct cause why this may happen. There is believed to be a genetic component to it, so you can thank mom and dad for parts of it, especially if there's reoccurring episodes of this. Most of the time, once it goes away, it may not come back. If we're having lots of recurring episodes, it still may be positional vertigo, and the roll technique can be helpful for you. However, if we're having reoccurring or persistent symptoms, this may not be the true cause of your vertigo. There are other reasons why you may develop vertigo. In fact, there's dozens of other reasons why you may. It may be due to certain medication toxicities. We do know that there are several that can cause inner ear dysfunction or even permanent loss. You may develop a phenomenon called Meniere's disease, which you will usually have ringing in the ear, feeling of pressure or water, or like stuck in your ear, and you'll have hearing loss associated with that side too when you're having symptoms. And it sounds like we have a question. I mean, there's more that we'll talk about, but I want to make sure we answer questions immediately. So, Kelly, what do we got?
It's not a question, it's feedback from Lonnie. Audio video keeps cutting out, starting and stopping.
Audio video again, right? Are we connected to Wi-Fi? Or are we? Interesting. Okay. I hope it's not a Facebook thing. We've avoided using even just the Wi-Fi here too, because we figured that was maybe the cause of our issue initially. If it continues, yeah, let's just keep giving feedback about audio video, because it may just be a temporary phenomenon. If not, I'll apologize in advance, and hopefully the playback with this won't have that same issue. If you need to go back, it should be kind of capturing all of this. Other causes, again, you can have, we touched on it briefly, like an inner ear infection. We call it a vestibular crisis. If you have an infection of the inner ear, which tends to come about from like a respiratory infection, or sometimes a gastrointestinal infection, it can actually make its way into the inner ear. Those just tend to be two types of viruses that make their way there. If that happens and you get that inner ear infection, most folks end up going to the ER because it's so bad. They actually think you're having a stroke. Your symptoms are so severe and so new onset. Oftentimes accompanied with severe nausea that you go and get checked out. And so if that phenomenon happens, we can differentiate. The ER, still go to the ER. Definitely don't not go to the ER, but go to the ER, get checked out. They'll tell you something else is going on, that you have an infection. But if we have vestibular or vertigo complaints from any kind of lesion or issue with the inner ear, it has a treatment. It's just not the same treatment as that roll technique. It's a different series of exercises that are done consistently in order to try to adapt the remaining structures in that area to work better. Right, and then also to make your body less conditioned to the severity of the symptoms through repeated exposures to that. And then that was a fancy way of saying we want to provoke symptoms a little bit so your body gets kind of used to it and it's less intense and less debilitating especially. The key thing that we look for when we're examining for these vertigo complaints is screening out any additional other issue that may be contributing to this and being sure that this is truly positional vertigo before we do a roll technique and not something else going on. And the first place that we look with that is with the eyes. So we go through a series of screening movements, watching your eyes move, watching them track, watch them move between targets, watch your eyes as they maintain a fixation on something with your head moving, and all those different movements help your clinician to determine truly kind of where that issue lies, because many of those things that we screen for with the eyes and head movement, many of those won't necessarily provoke your symptoms with positional vertigo. And if you're not having positional vertigo but still dizziness complaints, that will elicit some symptoms potentially, but also whomever is screening you will be able to observe what is happening and make a judgment on where to proceed from there. Again, that would take a different type of treatment than the roll technique, which we'll demonstrate today. Again, they can be fixable. Most vestibular issues over time will start to improve just because of time and your body kind of adapting to the new norm. And so vertigo complaints themselves, vertigo symptoms, I should say, are very highly adaptable. Your inner ear gets very much used to changing stimuli, right? That's why, again, when you're on a boat for the first day or two, it may be kind of uncomfortable, but you kind of get used to it if you've ever been on a cruise, and hopefully it's a good experience for you, but after a few days, you kind of almost stop noticing some of that motion as much because your inner ear is good at attempting to adapt to these what are perceived as odd movements. Okay? And the same thing will happen if we have an issue within the inner ear. Your body will start to accommodate to that to some extent and correct for it. It may not be complete, but it does happen over the course of weeks to months to attempt to self-resolve. And that will mask some of the tests that we use to screen you if it's been going on for some time, which is why a lot of these vertigo complaints we don't want to delay with treatment. We want to be able to capture fully what may be going on and initiate treatment as early on as possible, whether it be a rule technique or whether it be some sort of other form of intervention or get screened for something else. Because again, we can detect subtle signs of other neurological conditions with these same screening tests. And so that's the goal, is to not miss anything that's important that we want to treat somewhere else and not think that we're treating vertigo when it's truly not a positional vertigo issue. Okay. We still doing good on questions? Love it. Okay. So that's our basic anatomy. Again, the goal, like when we talk about positional vertigo, which is my kind of key thing I wanted to focus on today because it is so common and the key thing that we treat, I wanted you to be a little oriented with the anatomy, what it is that we're after. We're after getting those crystals out of the inner ear, okay? And so there are a few different techniques to do that, depending on which canal it's in. What I wanted to demonstrate for you today is what's called the modified Epley maneuver, right? Which is a technique to position the neck and head and go through a series of steps to try to empty out that canal. Okay. There are others. There's just the roll test or the lateral roll test. There's called the Apinelli, which is for this one of these ones that sit on the side, so one of the lateral canals. Currently, there's more and more evidence of another technique called the half somersault test or movement that works similarly to what we're going to do today, but frankly, most patients don't want to start getting into handstand or somersault positions, so we don't usually go there unless we're not seeing success with this one. So there are other techniques out there. I do acknowledge that. This is just the kind of bread and butter way of addressing vertigo movement. Okay. So I wanted to show you that today so you're comfortable with it, because if you are experiencing symptoms and we do this test, you do get vertigo. I mean, in fact, it should trigger it specifically when we go down into the initial movement. You will get your vertigo. You will feel like the room is spinning. That is normal. In fact, we want that. And you will get vertigo in various steps throughout this. Just know that it is controlled and welcome, and part of the necessary. It's necessary to go through the full step and frankly have some symptoms happen while we do it. I have yet to have anybody actually vomit on me, but you may get nauseous too. But again, it's normal to just feel all those same symptoms you usually feel. Okay. I'm gonna steal Kelly for this demonstration, so you guys can see what it looks like. Yes, so we'll be on this side here. So with this test, your patient, right, will be sitting with your feet on this side, so long sitting. So, and you want your body to be lined up so that your shoulders are going to be right about the break in the table. Now, I understand most of you at home don't have a table that goes up and down and has a head adjustment like this. When we're cueing you to do this at home for your routine maintenance between, the edge of the bed seems to be best for this. It's soft. You kind of relax your head over the edge. So doing this on the bed is kind of the best place to do it. I'm going to have you scoot a little bit further over to the right side and then a little bit further down on the table. That should be perfect right there. Okay. Now, again, sometimes you may not have this great hamstring flexibility to sit with your legs straight like this. If you need to bend your legs with this, you can. We're going to do a roll technique for her right side. Okay, so the position of this does matter whether we're talking about right side or left side. Typically, the first thing I'm looking for with symptoms, if I'm going to decide which side is more bothersome, I'm listening for when you tell me that when you roll over in bed, that's when you get your symptoms, and I want to know which way. If you roll over to your left, you roll over to your right. If you roll to your right and you get more symptoms, it's likely the right side that has the problem. If you roll to your left side has the problem. It's typically your left. It's not perfect, but it's kind of an early way that you can kind of self-determine which side may be going on. Since we're doing our right side, okay, we're going to start off with the head rotated exactly 45 degrees, okay? And we say exact because the precise head movements when we do this and holding for the correct amount of time is critical. That's why most of these roll techniques are not successful. We're either not in the right position or we don't hold it long enough because you just don't want to be there because you're uncomfortable. So we need it to be exact and we need to hold it for long enough, okay? So we're about 45 degrees, okay? I like to pre-position with bringing the head back because when you come back, you're going to drop your head back as far as you can tolerate. Now you do have to have enough motion in your neck to tolerate this, so you should kind of check, hey, can I turn my head 45 degrees, look up at the ceiling, how far can you get? You want to be able to make sure you have the neck motion to do this. So 45 degrees, back a little bit. I'm going to have her hold on to me because we're going to go down fast. It's going to make her feel more comfortable. When you're doing this on your own, sorry you don't have me to hold on to. And we're going to go down fast, okay? Now I'm going to actually take the glasses off if that's okay, right? Let's do it for you, right? It's weird when someone else does it. And again, cause I'm doing this now. You wouldn't have to necessarily take off your glasses at home, but I want to do this where I can see the eyes. Because when we go down in this position, you will get symptoms, but I need to see your eyes because they will beat a certain direction, both with rotation and movement. That tells us, again, which canal may be affected, and it also lets us know how intense and how long your symptoms are present, because as long as you're having vertigo, your eye will move. We call it nystagmus, right? Where, again, usually that posterior canal that's affected will cause a torsional upbeating nystagmus. So it twists and it beats upward while you're having your symptoms, okay? And we can see this as a clinician. It's not just you feeling it. We can watch it happen in real time. So I want to see that, so we need a clear view of your eyes. So we'll turn 45, back a little bit, holding on to forearms, and we're going to go down on 3. We're going to go 1, 2, 3. We're going to go down fast, right? It's kind of scary, right? But speed matters. We get a better maneuver when we go down quickly, okay? And I'm just watching her eyes, right? She's keeping them open for me. I'll let her know when it's cool to close them. Kelly, you can close your eyes if you want to, right? And we're just hanging out there. Now, again, I mentioned we want to hold it long enough. What that means is minimum of 30 seconds in this position, even if you're not having symptoms. But my rule is symptoms go away and then we wait another 15, okay? Imagine a snow globe and that snow settling, right? We need to let that snow settle before we move into the next position, okay? Now, when we're doing this in the clinic, I like to keep you supported the whole time with the neck. You can go ahead and relax your arms. I'm going to change positions here. Very good, okay? So keeping your head back, right? Next position. This one usually doesn't elicit more symptoms. We're going to rotate, keeping the head back. So we're just turning the other way, just hanging out. And again, waiting for that minimum length of time, let everything settle, or when you have symptoms, waiting for the symptoms to go away, and then a little bit longer. We're going to assume that's been long enough, just so we don't have too much run time here today, right? The next position is on your side, okay? And this is usually the tricky one to get right, where you keep your head in a good position. I'm going to have Kelly bend her right knee. It's going to make it easier to turn on her side, okay? She's going to tuck her left arm down, and right arm's going to come over across, because what we're going to do is turn on the side, and you're going to turn your head down so you're looking at the floor. So you're going to come across, boom. Here your head can be flexed a little bit. You don't have to be extended anymore, but you want to be ideally straight down, right? This is the second position where you usually get some vertigo again, right? Because at this point, a lot of that's starting to dump out, and that's going to be very stimulating to that inner ear. And so you may get symptoms here again too. Again, waiting long enough for symptoms to go away, then a little longer, or a minimum 30 seconds. Okay. Lastly, we're going to come back up to sitting. So our legs are going to kick forward. They're going to come off the edge. It's going to help make it easier to use your body weight of your legs to come up. We're going to push off with your arm, and we're going to set up over the edge. And again, you may feel weird here. You may get dizziness again. You may feel kind of a whooshing or discomfort. You know, a lot of different symptoms may happen here after we come back up from sitting. But that is a successful roll technique for the right side. If it was the left side, we just do it opposite. We start on the left side, turn to the left, go down, rotate right, then come back sitting up. Again, holding for long enough between each time. if that was successful, if we went down the first time and we had symptoms, we may choose to do the technique again. Sometimes we may not. Again, it kind of just depends on how intense your symptoms were. If they did manage to go away in those positions, again, indicative that it was true positional vertigo and not kind of a subtype that we'd have to do a different maneuver with it. After you're done with the roll technique, the current practice guidelines for management afterwards are to sit for 20 minutes upright, okay? It says quietly, but I mean, like, I feel like you can talk still. But again, the recommendation is quietly sit for 20 minutes. Again, it just means don't move around too much. Again, let that snow globe settle, or let the dust settle. It just has a higher success rate with the technique if we've allowed it to kind of settle without movement first. For the next 24 hours, you want to avoid bending the head downward, such as like putting on your socks and shoes or picking up something from the ground. You ideally want to be keeping your head upright when you're doing most things. So as you're bending forward, try to keep your head upright, because that's the goal. The whole remainder of the next 24 hours is trying to keep your head upright so that everything stays settled. When you bend down or you roll over in bed, those again are positions that kind of stir the pot a little bit, and so we just want to let everything settle. So no bending down, so staying upright and sleeping propped up on a few pillows. And so if you have a lot of throw pillows or something, you can kind of stack yourself up, make a little ramp. You want to be at least 30 degrees upright, if not more, from laying down flat. And so that's usually feels pretty aggressive. If you have a bed that adjusts to that, cool, you're lucky. Most people don't, but you can adjust it up higher. Some people find comfort in sleeping in a recliner if you have it too, where you prop it up where it's just enough. Sometimes, again, if you have access to that, that can be just more comfortable than building a ramp. But the old recommendations used to be, wearing a soft collar for a few days, sleeping upright in a chair for 3 days, literally vertical. It was much more invasive following this procedure, and we found that patients weren't doing it, to be honest, and so again, I wouldn't either. But we found that it was no more effective than these current recommendations either. So it's just kind of overkill. So don't feel like you have to wear a soft collar. You don't have to sleep upright for 3 days. You can still do movement. You can still be somewhat normal. We just want to stay somewhat upright for the next 24 hours. We usually give this to you as home exercises too, to complete yourself over the next few days. It is advised to do successive bouts of the roll technique to ensure that it has improved, right, that we've made a difference. So if you were to come in, if Kelly were to come in tomorrow, she was experiencing symptoms then, and she came in tomorrow, we did that first drop again, we should see a significant reduction, if not a complete elimination of her vertigo. So that's what we want to look for. We want to make sure, hey, did this clear? Did this improve? Did this change? And how much more intensive intervention does it need? Because we should see it go away. In fact, over 83% of patients will improve completely with these symptoms within 3 roll techniques. So it's got a very high success rate. I mean, that's a slam dunk treatment. Like, if you have vertigo and you roll 3 times and you've got better than 4 out of 5 chance that it's gone, I mean, you can't beat that in anything in healthcare. So that's real good success rate. So this is treatable when it's a positional vertigo, and this is usually that first go-to to attempt to treat vertigo complaints, because it's so easy, it's so fast, it's non-invasive, as long as you're kind of passing all the positional tests that suggest that this is the case, that we're treating the right thing. Okay? So we have a question.
Do you have printouts of the vertigo exercises?
Yeah, so I do have printouts of both the roll technique for the right and the left side. And then we also provide handouts for any of those other exercises, like what we call adaptation exercises and habituating exercises. And those are made available if that's what's appropriate for you. So we do have handouts. Is that something that we were wanting to have posted for use, or just general inquiry if that's something we provide?
Just general.
I might post them. Yeah, we'll see. So, yeah, I can make these things available in the roll technique with the Epley maneuver. And this is usually advised to continue until symptoms are gone, at least for several days, before initiating some other type of treatment. Okay. Again, very high success rate. Again, if we do screening beforehand, we can sometimes catch some of these other things that may be contributing to vertigo. didn't intend to do other vestibular or vertigo treatments today because they start getting a little bit different and nuanced, and frankly, it's a very small percentage of people that end up utilizing these types of interventions that I didn't think it was appropriate today. But if we have a lot of interest, this is something we can put together. We can talk more about other vertigo complaints and what do we do about those ones if the roll technique doesn't work. Where do we go from here? Happy to do that. I think that was most of what I had planned today. So we talked about what it is, why it is, how it works, why PT, right? Not catching others, why is it not something else? So my objectives are filled. Do we have any more questions? Are we good? Okay. That's vertigo. Super easy to treat, one of my favorite things. If you know of anybody that's experiencing vertigo, or you yourself are experiencing vertigo too, super easy to, again, get in and get an evaluation and run through this technique, because we can oftentimes, a lot of the time, clear it up even just that same day. So reach out if you have further questions or concerns. Thanks, guys.